people who are very disenfranchised, abandoned and isolated and self-harming and feeling quite a lot of despair. So where to start? Okay, where shall we begin with all of this? Well, always just making it very clinically relevant. I always start when I see a new person by just being friendly. Hey, nice to see you, welcome in. Would you like a glass of water? And now, that's not just being friendly, because if you make good eye contact, Stephen Porges tells us this, if we are very friendly and make good eye contact and are supportive, that starts to settle the nervous system. So we're being friendly not just to be friendly, we're being friendly to do therapy. We're being friendly and supportive and compassionate and connecting so this person's nervous system can start to settle. And a drink or a drink of water impacts the vagal nerve, which means the respiratory rate slows down, the heart rate slows down. Things start to slow down. So I always give my clients a cup of water. Well, that's if they want one. If they don't want one, that's fine. Okay? But they're offered a little glass of water. So they periodically can pause and have a sip. Pause and have a breath. Pause and have a rest. Because the adrenal system is pretty relentless. So water, I used to work in New Zealand. We wouldn't do anything without offering food and or tea, coffee, water. We wouldn't ever work with a Maori family or Pacific Island family without that. That was a standard cultural protocol. Okay. So, people try and get clients to learn how to meditate. No. Just one breath is what you want to aim for. Just getting a client to take one. Pause and take one deep breath. Meditation's a bridge too far for our clients. But we don't want to give up, but we do want to bite-size it. So one breath. And homework is not to go and meditate. Homework is to go and steal a breath somewhere. Okay? And deliberately use that word, steal a breath. Because no one's going to give it to you. No one's going to say, hey, why don't you take a breath? No one's going to say that to you out in the world. So the client has to learn to steal a breath. Sips of water as we go along, and stealing a breath. So, I want to move on and clarify, are we going to follow the scientific method or are we going to follow a belief in science here? Because they're two different things. And I want to say that from a counselling perspective, I'm going to inform myself about all things trauma and all ways of working with people and being very trauma informed and so on. But I'm going to work with the client in the present moment, which means I'm going to try something and see the impact of it and adjust myself based on the impact. It's all trial and error. I'm going to say something and watch how my client responds to that, and then I'm going to adjust myself based on how they respond, and then I'm going to do my next intervention. And then I'm going to track the outcome of that second intervention and see how they respond to that, and then I'm going to adjust myself and offer a third intervention. And the whole session's going to be going along in this format, paying attention to how my client responds to the moment, and how I respond to them, how they respond to me, and how we can shepherd our way through. So arguably, that is the scientific method. Yeah, you're adjusting yourself based on the feedback of what you're measuring, what you're paying attention to, what you're dealing with. Okay, and so that's the primacy of things, which our good friend Ian McGilchrist would say that's the right hemisphere of the brain working, and the right hemisphere as master. And Ian McGilchrist wrote that book, The Master and His Emissary, 2008. The Divided Brain and the Making of the Western World. Okay? And his whole thesis was that the Western world has gone far too much into the left hemisphere's view of life, which is all about the past and all about the future and all about some form of grandeur and grandiosity and language and status and, oh, I have a PhD and I have a double PhD and, oh, you know, so and so on. It's all of this stuff which is not so much relevant for the moment-to-moment relational dynamics that you're just adjusting to as you do. So my argument is the same as McGilchrist's argument, which is to keep ourselves very much attuned to this present moment, what's happening in the work that we're doing, adjusting yourself consistently and continuously throughout your work with people. And in that way, maintaining the scientific method in a very, it's alive right now way. Okay? And also consult your textbooks and your supervisors and other people to get feedback and so on. But clients are our best teachers. I touched on this before, levels of evidence within the complex trauma field, and we're down the bottom there, in the green. So we're looking at expert professional opinion from credible peoples across continents and across time. We're using the best pieces that we can find. And there is gradually a body of evidence coming along. In 2013, they tried to get complex post-traumatic stress disorder into the DSM. It didn't get up. And the reason it didn't get up, there's not enough empirical evidence on it as yet. Fast forward to 2022, last year, and we do have complex PTSD turning up in the, where did it turn up? International Classification of Diseases, ICD-11. So they've beaten the Americans, the Europeans have beaten the Americans. So you can, and we do speak about complex PTSD, and it is in the World Health Organization International Classification of Diseases, Volume 11. Oh, and there's Ian McGilchrist there. We're talking about the left brain and the right brain. Fundamentally trying to keep ourselves knowledgeable with left brain knowledge, but connected and present and skillful and compassionate with the right hemisphere's present moment, present consciousness of things. But that's another thing about mindfulness. A lot of therapies across the board try and make clients mindful. They want you to go and make these clients mindful. And I say to my students, no, it's you that have to be mindful. The client has a prerogative to be all over the place. They have a prerogative to go and get drunk. They have a prerogative to whatever they're going to do. They have the right to be as unconscious as they want to be. That's their life. But I, as the professional, as the worker, I should be paying attention to this person and this moment and seeing what I can do. Yeah? Bring all of my consciousness to the present tense and see what we can do together. So I reframe with my students, it's you guys, the students, that have to be mindful. Take it easy with your clients. Sometimes don't even mention the word mindfulness because people freak out. They say, oh, my last therapist, they tried to do that with me, it doesn't work. Of course it works, it's just the way you do it. You've got to be skillful with how you do things. So don't use the term. Okay. Understanding post-traumatic stress. So before we get to complex post-traumatic stress, we have had PTSD since 1980 in the DSM. It came into the DSM in 1980 because of veterans returning from the American War in Vietnam. Okay? Back to America, back to Australia, back to other places, the UK and so on. Healthy young men and women went over there. A lot of young men and women came back and had significant addiction issues, significant mental health issues, so on and so on, and significant amounts of suicide post the Vietnam War in particular. As all wars, we're getting more and more suicides of veterans. It's really alarming. But initially in 1980, it was a behavioural psychology, which means back in the day, stimulus, response. The bigger the tsunami, that's a stimulus, yeah? The bigger the bushfire, the bigger the war zone horrors, the more response around PTSD symptoms you'll have. The bigger the tsunami, the more you'll be traumatised. That was that thinking back in 1980. But then Soldier A came back. Soldier A is fine. Soldier B is a mess. So if everyone's being exposed to these horrors, shouldn't everybody be a mess, given that stimulus response psychology? Well, yes, they should be, but Soldier A is fine. It's only Soldier B who's suffering. So after 1980 DSM-3, we get to DSM-4 in 1994, and they throw out the stimulus response way of conceiving, of perceiving. They say, actually, it's more a cognitive model that's important for us to understand. So what is the cognitive model of post-traumatic stress? Well, it's what you brought to the event. The antecedent things, A, B, C. The A is the antecedent resiliences, resources, strengths, or vulnerabilities, difficulties, prior stresses, younger stresses. So what did you bring to this traumatic event, which was strengthening or weakening for you? And then what did you make of this horrible thing? Not just what happened, but what did you make of that? What beliefs did you form? What was your perception of this? And we know the perception of life ending, life threat, I'm going to die here. We know that that increases people's PTSD risk. If you've got 10,000 people who've been exposed and you've only got 2 seconds per person to interview them to see if they're going to be in the follow-up or the wait and see group, you're going to go, the one question you're going to ask them was, hey, I'm sorry that happened to you, but what did you think about what happened to you? Did you think you were going to die? If they say, no, I thought I'll be okay. Oh, okay, you give us a call if you need to. And if someone says, yeah, I thought my life was over. It flashed before my eyes. I thought I was dead. Well, that person, do you mind if we give you a call in a few days and follow up, get your phone number? See, that's the life threat. So the perception of things, and then the C, so A, B, B is the beliefs and perception, and C is how were you treated afterwards? And we know from the Royal Commission that Julia Gillard did into institutional childhood sexual abuse that so many kids tried to put their hand up and say, the priest is touching me, the brother is touching me, the teacher is doing things that are not good. And a lot of these kids were met with, don't speak about the priest that way. Do not complain about your teacher. Do not make up these stories. So afterwards, you're trying to get help. How did the community treat you afterwards? What was the response? Okay, were you met with support, or were you met with shame and ridicule and dismissal? And we know the sad legacy of the returning soldiers from Vietnam. It was a very unpopular war. They weren't warmly welcomed upon their return. And then DSM-5 follows on from DSM-4. We have the A, B, C, the cognitive model of post-traumatic stress. And we have some extra features. So let's look at post-traumatic stress. What are we looking at in their features? Well, you've got exposure. Exposure to something that's really horrible, overwhelming, life-threatening, or you're witnessing that in somebody else. And you usually have to wait 4 weeks for symptoms to emerge and diagnoses to occur. But then the common symptoms that have always been there since 1980 are the intrusive, avoidance, and hypoarousal. They have been there since 1980. In 2013, we get the addition of that 4th dimension, which is negative alterations in cognitions and mood. Now, when Rape Crisis Services Australia started to look at this, they said, well, we've done some research on this, and what does this mean? It means when the victim blames herself. Boils down to, it's my fault I was raped. I should have gone home when my friends went home, but I stayed at the club. I jumped in the car with him. It's not him, it's me that's the problem. So when the victim blames herself, blames themselves, mostly that's what that boils down to. Intrusive, of course, you get flashbacks, you get thoughts, you get feelings. You're trying to make lunch, you're trying to get the kids off to school, you're trying to fall asleep, and you get this image, this memory, this feeling that you don't want. It's intruding upon you. Trauma-based stuff. Avoidances are, of course, I don't want to talk about it, I don't want to go there, I don't want to see a doctor, I'm not seeing a counsellor, I don't want to go out, I don't want to go to work, I don't want to go back to uni where it happened, I don't want to do things. And of course, arousal, alterations in arousal and stuff is ups and down of the mood system. Now, to make all of this more logical, we say it's all about avoidance. Okay? How do we understand the organisation of how people cope with trauma? The number one thing people tend to do to cope with trauma is avoid it. Okay? You put a single cell organism in a petri dish and in the right viscosity, the right temperature, and then the membrane spreads out. You're looking at it through a microscope. And then you put a little bit of sewing machine oil in the corner of the petri dish. And the membrane that's closer to the oil starts to withdraw away from it. Now there's no higher order brain going on there. It's not thinking, oh crap, there's some oil, I've got to get away. There's no thinking. This is on a cellular level. On a cellular level, the human organism wants to move away from explosions. Wants to move away from horrible things. Doesn't want to be around horrible things. And that's fine if you're an adult. You can get up and go. But what if you're a little child? You can't really pack your bags as a 2, 3 or 4-year-old, can you? This is some of the complexity of the trauma that we're about to get into. But it's all about avoidance. The more I avoid, the more I get haunted by intrusive memory, intrusive image, intrusive thought. Okay? The more I get intruded upon, the more my nervous system gets reactivated and hijacked, and the more I blame myself and hate myself again. So what do I do further? I go into further avoidance. Drugs, alcohol, gambling, self-harm, I want to kill myself, don't want to be here, not leaving my room, pulling the blankets over, so on and so on and so on. Avoidances.